Imagine sitting in a doctor's office. You're there for a routine procedure, maybe a transvaginal or, transrectal ultrasound.
Right, something super standard.
Exactly. The room smells faintly of sanitizer. The doctor turns to the machine, unwraps a fresh, disposable plastic cover with that really reassuring crinkle, and just slides it right over the medical probe.
And in that moment, you probably feel completely safe.
You do. You assume that because that barrier is single use, it's sterile, and therefore your risk of infection is absolutely zero. But what if that assumption is dangerously flawed?
Yeah, that's the big question we're looking at today.
Because today we are completely tearing apart the medical dogma around disposables. We've pulled data from the CDC, the UK Health Security Agency, and these really deep clinical trials across Europe.
Some really fascinating studies in there.
Definitely. And our mission is to answer a question that seems simple but is actually deceptively complex, which is, are disposable medical probes and devices actually safer than reusable ones?
Okay, let's unpack this, because the deeper you look into this stack of research, the more that crinkly plastic cover starts to look a lot less like a shield and, well, a lot more like a liability.
It really does. The thing is, the safety of a medical device goes so much deeper than just the physical item itself. We are conditioned to see single-use plastic and immediately register it as clean, totally risk-free.
Right, it's fresh out of the package.
Exactly. But in clinical reality, safety is dictated by this invisible ecosystem. It's the microscopic risks, the inevitability of human error, and this actual chemical warfare happening at a cellular level that we simply never see.
Wow, chemical warfare.
Yeah, and to really understand the risk profile of an ultrasound probe, we first have to break our own intuition about what reusable actually means in a medical setting. Because we really do have this deep-seated belief that single-use disposable always equals fewer infections. I mean, think about the debate between bottled water and tap water.
Oh, that's a great comparison.
Right. We have this bias where we assume the disposable plastic water bottle is magically pristine just because it's sealed in a factory. But the reusable system like municipal tap water is subjected to continuous, really rigorous testing and chemical regulation.
Which is often way stricter than the bottled stuff.
Exactly. Our bias toward disposable medical gear feels like a symptom of our modern throwaway culture. So I think we should look at some simpler medical devices first to see if that bias actually holds up, starting with urinary catheters.
Yeah, the research on catheters completely challenges our modern medical dogma.
Right.
We have this major study from the University of Southampton, and it was funded by the National Institute for Health and Care Research.
Okay, so a very reputable source.
Very. They conducted a year-long investigation looking at patients who use urinary catheters. And these are simple plastic tubes used to empty the bladder, sometimes up to 4 times a day.
Which is a lot of plastic if you're throwing it away every time.
Right. And the standard assumption by health professionals everywhere is that you use a fresh catheter once, you throw it away, and that single use prevents urinary tract infections.
Which makes intuitive sense. You're introducing a foreign object into the body. A fresh tube straight from a sterile wrapper shouldn't have any bacteria on it at all.
That's the logic, yeah.
Whereas washing and reusing a tube at home, that sounds like you're just inviting bacteria in.
You would think so, but the data tells a very different story. The researchers followed hundreds of patients, comparing those who used single-use disposable catheters exclusively with those who mixed in cleaned, reusable catheters.
Okay, and what did they find?
Well, the patients using reusable catheters actually required 35% fewer antibiotics over the course of the year.
Wait, 35% fewer antibiotics?
Yeah.
That is a massive, clinically significant drop. Are you saying they got sick less often?
The infection rates completely back it up. 29% of the group that mixed in reusable catheters had at least one UTI in that year. Compare that to the single-use group, where the infection rate was actually higher, at 34%.
So the people throwing away the plastic every single time were actually getting sicker.
They were. If we connect this to the bigger picture, when a device is simple and straightforward to clean, reusables are incredibly safe. And we see this successful pushback against throwaway culture working in other areas of gynecology, too.
Oh, like what?
Well, the clinical sources detail something called the Uresta pessary. It's a structural support device used for pelvic organ prolapse. It sits inside the vaginal canal, but it is uniquely designed to be fully reusable for an entire year.
Oh, wow, an entire year.
Yeah, patients just clean it themselves. It offers immense environmental benefits and cost savings, and clinical trials confirm it doesn't sacrifice patient safety at all.
So if a reusable tube and a reusable pessary are totally fine, the obvious question is, Why are reusable ultrasound probes causing so much concern in the medical community?
It's a completely different ballgame.
You're right. Why does the safety profile completely change when we move from a piece of shaped plastic to an endocavitary probe?
The difference really comes down to geometry and electronics, and how those two factors basically dictate our cleaning protocols. There's this universal framework called the Spaulding classification.
Okay, the Spaulding classification.
Yeah, it was developed in the 1960s to determine how intensely a medical instrument needs to be disinfected. And it has three tiers. Non-critical devices, like a blood pressure cuff, only touch intact skin, so they just need a basic wipe down.
Makes sense.
Then you have critical devices, like surgical scalpels. They enter the bloodstream, so they must be completely sterilized. But endocavitary probes, like those used in vaginal or rectal ultrasounds, fall into the middle tier. They're classified as semi-critical.
Because they come into direct contact with mucous membranes?
Right.
And those are essentially a fast track into the bloodstream and internal systems compared to, the tough barrier of intact skin.
Exactly. You can't just wipe them down like a blood pressure cuff.
Right.
And you also can't easily sterilize them, like a scalpel. Ultrasound transducers are incredibly complex, sensitive pieces of equipment.
They're essentially high-tech computers on a stick.
Pretty much. We're talking about multi-thousand-dollar electronic devices packed with delicate piezoelectric crystals. You cannot throw a $5,000 piece of tech away after a 10-minute scan.
No, obviously not.
And you can't throw it in an autoclave to blast it with extreme heat and pressurized steam either. It would just melt.
Which brings us back to the crinkly plastic from the beginning. Since we can't throw the probe away and we can't boil it, the standard protocol across the medical world is to take this expensive reusable probe and cover it with a cheap, single-use disposable condom or a plastic sheath.
Right.
We just assume the barrier handles the semi-critical risk.
That is the assumption. But the terrifying reality is that the disposable barrier fails constantly.
Consistently fails.
Yeah. The studies we reviewed show that standard condom perforation rates range from 0.9% to 5%. And one particularly granular study noted that 65% of those microscopic leaks happen within 10 centimeters of the tip.
The tip. The exact part of the probe that is experiencing the most friction and making the most direct invasive contact with the mucous membrane.
Exactly.
But wait, if we know cheap condoms are failing at up to 5%, why on earth do we even bother with them? Or, actually, I'd assume clinics are buying high-end, purpose-built medical sheaths to fix the problem, right?
You would think so. But the older baseline data on commercial probe covers is actually way more alarming. Studies on those purpose-built sheaths showed staggering failure rates, anywhere from 8% to 81%.
81%. That's barely even a barrier.
I know. Now, manufacturing has improved since some of those initial baseline studies, but the failure rate is unequivocally never zero. The mechanics of the procedure, the pressure, the friction, the physical geometry of the probe, it means that microscopic tears are just inevitable. And because the disposable cover fails, the underlying reusable probe is frequently exposed to the patient's bodily fluids.
Meaning it's exposed to whatever pathogens that patient might be carrying. And the sources list some incredibly resilient and dangerous ones like HIV, hepatitis C, cytomegalovirus, and high-risk human papillomavirus, or HPV, which is the primary cause of cervical cancer.
It's a serious lineup of pathogens.
It really is. So the safety of the next patient relies 100% on what happens to that reusable probe after the leaky disposable cover is thrown in the trash.
Which brings us to the chemistry of disinfection and a very dangerous gap between theoretical guidelines and actual clinical practice.
Right, because theory and practice are rarely the same thing.
Exactly. Because the probe is semi-critical, organizations like the CDC and the Society for Maternal-Fetal Medicine explicitly require what is called high-level disinfection, or HLD. This involves harsh, highly effective chemicals like glutaraldehyde, hydrogen peroxide, or parasitic acid.
But the data shows clinics are routinely taking a shortcut. They are skipping the heavy-duty HLD chemicals and using low-level disinfection LLD.
Yeah, usually just a quaternary ammonium wipe or a standard sanitizing spray.
And the difference between those two cleaning methods is a matter of profound clinical significance, specifically because of the biology of the viruses involved. Low-level disinfection is fast and cheap, but it is highly ineffective against non-enveloped viruses.
Exactly, and we really need to drill down into that because the mechanics of how a virus survives a chemical wipe are fascinating.
Well, when we hear the word virus, we usually picture something like a flu virus or COVID-19. Those are enveloped viruses.
Right. Enveloped viruses are essentially wrapped in a fragile outer lipid membrane, basically a layer of fat. When you hit them with a standard LLD sanitizing wipe, the chemicals easily dissolve that fat layer, popping the virus like a soap bubble
So it's destroyed instantly.
instantly. But HPV is a non-enveloped virus. It doesn't have that fatty outer layer.
It doesn't. Instead, non-enveloped viruses like HPV are encased in a tough, tightly knit protein shell called a capsid.
And using a basic fat-dissolving LLD wipe on a protein shell does absolutely nothing.
Here's where it gets really interesting. Using an LLD wipe on a semi-critical probe is like wiping down a wooden cutting board with a dry paper towel after cutting raw chicken and then immediately using it to chop a salad.
That is a terrifying but very accurate analogy.
It looks clean, but the microscopic danger is entirely intact. The chemicals literally just slide right off that protein armor. High-risk HPV, specifically oncogenic strains 16 and 18, are incredibly stubborn. Our sources note that because of that protein armor, HPV can survive on a surface completely dehydrated for 7 days.
7 days. A week later, that virus is still just sitting on the probe, fully viable.
That's insane.
And the French clinical studies bear this out with hard, terrifying numbers. Researchers went into clinics, took probes that had just been cleaned with standard LLD wipes, and swabbed them. They found that 13% of those LLD-treated probes retained HPV DNA.
13.
Yeah, and to prove just how dangerous this was, they tested that DNA and found that 7% of the samples were nucleus resistant.
Okay, wait. What does nucleus resistant mean in this context?
So nucleases are enzymes that act like molecular scissors. Their entire job is to chew up exposed, unprotected DNA. If you apply nucleases to a sample, the viral DNA survives. It proves that the virus's tough protein armor is completely intact.
Oh, I see.
The DNA is still locked safely inside the vault. It means the virus wasn't just dead fragments smeared on the probe. It was highly viable and perfectly capable of infecting the next person.
So using a basic low-level wipe on a semi-critical ultrasound probe leaves the viral vault completely untouched. When the French researchers ran a massive simulation based on this swab data, they estimated that 1 to 6% of patients could be infected by these contaminated probes.
Which translates to huge numbers on a national scale.
Exactly. In France alone, they calculated that LLD failure could result in roughly 60 new cases of HIV and up to 15,000 common viral infections every single year, just from ultrasound probes.
15,000 entirely preventable infections.
If the biological science is this clear and the failure rates are this high, why on earth would any clinic risk using a simple wipe? If you know the cover leaks and you know HPV ignores a basic wipe, why aren't all clinics universally using high-level disinfection?
Because it's a tragic tug of war between clinical efficiency, equipment longevity, and patient safety. Think of it like trying to clean a luxury smartphone in a dishwasher.
The dishwasher analogy is perfect, yeah.
If you put a smartphone through a heavy-duty dishwasher cycle, you will absolutely kill all the bacteria on it. But the harsh environment, the extreme chemicals, and the moisture will inevitably degrade the sensitive electronics inside.
Right, the phone would be ruined.
And high-level disinfection does the exact same thing to ultrasound transducers over time. The chemicals eat away at the adhesives and the lenses.
Plus, soaking a probe in something like glutaraldehyde takes significant time between patients. It often requires special ventilation rooms because the chemicals emit toxic fumes.
It's not a quick process.
No, and the sources point out that in specific settings, like fertility clinics, there are major concerns that trace residues of these strong disinfectants could be toxic to patients or even embryos.
So the clinician is looking at a waiting room full of anxious patients, a probe that will degrade if soaked in acid,
Right.
and a cleaning process that requires a hazmat setup. They look at the disposable plastic cover and think, well, the cover probably got everything. Let's just use the fast wipe.
Wow. So the reliance on the disposable cover creates a false sense of security that actively justifies substandard cleaning.
Exactly.
We've heavily scrutinized the probe itself, the leaky cover, and the chemical warfare used to clean it. But there is a third, often completely ignored variable in this ultrasound equation that perfectly captures this whole disposable versus reusable debate.
Why, yes.
The coupling agent, the ultrasound gel.
The gel is the hidden smuggler in the ultrasound clinic.
That's a great way to put it. We have extensive guidelines here from the UK Health Security Agency entirely focused on ultrasound gel. Because standard ultrasound gel, the stuff that comes in those big squeezy bottles that get used on patient after patient, That is a reusable multi-patient product, and it is entirely non-sterile.
And that lack of sterility has had severe systemic consequences. The UK guidelines were practically forced into existence because of multiple outbreaks of severe bacterial infections linked directly to contaminated non-sterile gel.
Just from the gel.
Yeah, specifically strains like Burkholderia cepacia and Pseudomonas aeruginosa. And these are not minor bugs. They can lead to bacteremia, which is bacteria actively multiplying in the bloodstream, and severe respiratory tract infections.
But why are these specific bacteria growing in the gel in the first place?
Well, Pseudomonas aeruginosa, for example, is a notorious water-loving bacterium.
Mhm.
It thrives in moist environments. You often find it colonizing hospital sinks and plumbing systems.
Oh, gross.
Right. And ultrasound gel is highly aqueous. It's rich in stabilizers that bacteria can feed on, and clinics often keep the bottles in warmers for patient comfort.
Oh, no. So a warm, dark, nutrient-rich bottle of water-based gel is essentially a luxury spa for these bacteria.
Exactly. When a sonographer uses a multi-use bottle, if that nozzle touches the air, the patient's skin, or the probe, it can draw bacteria right back into the gel, where it rapidly colonizes.
So you have a non-sterile contaminated gel. You put it on a probe, you rub it into the patient's skin. If that skin isn't perfectly intact, or if you are doing a transvaginal ultrasound where you are interacting with mucous membranes, you are driving the bacteria right into a highly vulnerable system.
This is exactly why the UKHSA guidelines demand a rigid shift to disposable, sterile, single-use gel sachets for specific high-risk scenarios.
Okay, so they are stepping in.
Yes. If the procedure is invasive, like a biopsy, if it's near non-intact skin, if the patient is in intensive care, or if it's a mucosal contact procedure, you absolutely must use a sterile single-use packet of gel. Use it once, and the packaging is discarded.
And even for the low-risk, standard exterior ultrasounds, where they are still allowed to use the big multi-use bottles, the rules are incredibly strict to prevent that bacterial colonization.
Extremely strict.
The bottle has to be dated the exact moment it is opened. It must be thrown away after 1 month, regardless of how much gel is left inside. It has to be stored completely upright so gel doesn't pool near the cap, and the nozzle must never touch the patient or the equipment.
Not even a little bit.
Right. If the tip grazes the plastic of the probe, the whole bottle goes in the trash.
Which requires an immense amount of discipline and constant situational awareness from the sonographer.
Hearing about these bacterial outbreaks, I actually have to push back on the guidelines a bit. If the big reusable bottles of gel are literally growing Pseudomonas and causing bloodstream infections, why not just mandate sterile, single-use gel packets for absolutely every single ultrasound, everywhere? Just ban the big bottles entirely and remove the risk.
This raises an important question, and it's a completely natural reaction. But it gets to the very heart of modern healthcare design and targeted risk assessment.
How so?
The environmental and practical impact of a universal sterile mandate would be catastrophic. Think about how many routine, low-risk, intact skin ultrasounds happen globally every single day.
Like physical therapists checking muscle tears.
As cardiologists looking at a heart through a healthy chest wall, standard pregnancy belly checks.
Millions. It's got to be millions a week.
Easily. If we mandated single-use, fully sterile gel packets for every single one of those routine exterior scans, the sheer volume of plastic waste would be mountainous. The manufacturing and shipping footprint would skyrocket, and the cost would cripple hospital budgets.
Okay, I see your point.
You cannot apply a maximum security protocol to a minimum risk scenario without breaking the entire healthcare system. We have to match the right tool, the disposable sterile packet, versus the carefully managed reusable bottle, to the specific clinical vulnerability of the patient in front of us.
So what does this all mean for us? We started this deep dive looking at a crinkly plastic probe cover, assuming that disposable automatically meant safe. But we've seen that the disposable versus reusable binary is a total myth.
It is a myth that can cost lives if we don't understand the mechanisms behind it.
We saw that reusable urinary catheters and pessaries can actually result in fewer antibiotics and fewer infections, challenging the idea that throwing plastic away keeps us healthier.
Right.
We learned that disposable ultrasound probe covers leak up to 5% of the time, and that this leaky armor creates a false sense of security that leads clinics to use weak, fat-dissolving wipes on tough, protein-armored viruses like HPV.
The cutting board analogy.
Exactly. And we saw that even the gel, acting as a bridge between the probe and the body, can be a smuggler for water-loving bacteria if we don't match the sterility of the gel to the risk level of the procedure.
But knowledge is only valuable if it is applied. And as a patient, this information gives you a new level of agency in environments where you usually feel powerless.
That's the biggest takeaway here. You are now empowered to walk into a clinic, look at that ultrasound machine, and ask your provider two very simple, direct questions. One, do you use high-level disinfection on your probes? And two, is that a sterile, single-use gel packet?
It's that simple.
You have the right to ask, and you have the right to know how the tools being used on your body are being managed.
You do. And as we wrap up, I want to leave you with a lingering thought. We are currently forcing our medical professionals to make impossible choices between patient safety, clinical efficiency, and environmental destruction.
It's a really tough spot to be in.
It is. As we finally reckon with the massive, undeniable ecological footprint of global healthcare, how will engineers design the next generation of medical tools?
Oh, that's interesting.
Right. Can we invent new materials, perhaps advanced polymers or self-disinfecting surfaces that offer the absolute biological safety of a sterile, single-use disposable, but possess the ecological sustainability of a lifetime reusable?
That is the multi-billion-dollar question. Until we invent that perfect material, we have to stay curious, stay vigilant, and never just assume we are safe just because we hear the crinkle of a fresh plastic wrapper. Thank you for joining us on this deep dive. Keep questioning those invisible systems around you. We'll see you next time.